This explainer is based on the literature review, Meniere's disease, a vestibular physician's deep review of endolymphatic eye drops, diagnosis, and management, published by Australian Dizziness Clinics, available at australiandizzinessclinics.com. Welcome back. All right, let's just dive right in. Today, we're putting the medical management of Meniere's disease under the microscope. And you know, managing Meniere's, it isn't about following some rigid one-size-fits-all recipe. Instead, it's really about executing a sequenced, highly tailored trial of measures. Now, I know the strict placebo-controlled evidence base for some of these steps can seem, well, a little modest, but their pragmatic effect, it is absolutely substantial when you apply them correctly in your clinic.
So let's kick things off with a highly encouraging baseline. 80%. That's the proportion of your Meniere's patients who are going to achieve adequate vertigo control using conservative and medical measures alone. Honestly, that's a massive majority, and it really underscores exactly why mastering these non-surgical steps is just so critical to your daily practice.
The management pyramid, lifestyle and acute attacks, preventive pharmacotherapy, intratympanic therapy comparison, summary, and next steps.
Section 1, the management pyramid, stepwise escalation. Let's establish our clinical map.
Okay, so this clinical ladder right here is the absolute foundation of our approach. We start down at the bottom with low-risk interventions, things like lifestyle and diet. From there, we escalate upward. We move through preventive and acute meds up to intratympanic injections before we ever even think about considering surgery at the very apex. Notice how increasing intervention inherently brings increasing risk. Each tier deliberately builds on the last, making sure we maximize conservative control before we escalate.
Section 2, Lifestyle and Acute Attacks, the foundation. Let's head down to the base of the pyramid. These foundational measures apply to pretty much everyone walking through your door. First up, sodium restriction. We're aiming for under 1,500 to 2,000 milligrams a day. Now, interestingly, while the high-quality trial evidence here is, modest, clinical consensus overwhelmingly supports it. It's just a benign, sustainable first step. We also want to target triggers, caffeine, alcohol, nicotine, along with managing stress and fatigue. And definitely don't forget hydration discipline. We want patients maintaining a nice, regular fluid intake, right? Rather than ping-ponging between dehydration and bolus drinking.
Of course, an acute attack will inevitably break through, so you need a pragmatic protocol locked and loaded. Step 1, provide a written rescue plan early in their care and supply them with rapidly dissolving or buccal antiemetics. Step 2, utilize short-term vestibular suppressants, think prochlorprozazine or diazepam, just to get them through the immediate crisis. And remember to reassure them that the attack will self-terminate. Finally, Step 3, introduce vestibular rehab. This is absolutely vital between attacks and especially after any ablative procedures to support central compensation for that cumulative vestibular hypofunction. But here is a stark warning we absolutely must heed. Quote, "The single biggest error in primary care management is continuous vestibular suppressant use." Look, the crucial takeaway here is that vestibular suppressants must be short-term only. If you leave a patient on continuous suppressants, you are actively blocking central compensation. You'll take a patient with episodic vertigo and actually leave them with worsened chronic disequilibrium. Long story short, never leave them on these medications long-term.
Moving to Section 3, Preventative Pharmacotherapy, Real-World Application. Let's step up to that middle tier of our pyramid.
So, when evaluating our preventative options, betahistine is the go-to maintenance agent in Europe and Australasia. It's commonly dosed up to 48 milligrams 3 times daily. Now, I know the strict BEMED trial showed no superiority over placebo, but real-world clinical experience and older meta-analyses, they still firmly support its use for attack reduction. Next, we have diuretics, things like hydrochlorothiazide, triamterene, or acetazolamide, aimed at reducing endolymph volume. Just remember to monitor those electrolytes, especially in your older patients. Also, if you see overlapping migrainous features, targeted migraine prophylaxis like propranolol or topiramate is extremely high yield. Seriously, it might even work better than escalating their Ménière-specific therapy. And finally, just to hammer this home, vestibular suppressants belong strictly in the acute phase. Never, ever use them for daily prevention.
Section 4, Intratympanic therapy comparison, the apex. Now we're climbing to the top of the medical management pyramid.
So, what happens when oral prophylaxis fails to control those debilitating attacks? Well, we bypass the systemic routes completely and deliver pharmacological agents directly through the tympanic membrane. These agents diffuse right through the round window and straight into the affected inner ear. It's a highly targeted approach, and it sits right there as our very last major intervention before we start having surgical conversations. But how do we actually balance this clinical calculus? Well, we're essentially weighing two distinct agents here. On the conservative side, we have intratympanic dexamethasone. It's non-destructive, it preserves hearing, and it yields a very respectable 60 to 80% vertigo control. But what if that just isn't enough? That's when we look at intratympanic gentamicin, which is chemical ablation. Now, this achieves an incredible 80 to 95% control, but the trade-off, you're looking at a 10 to 15% risk of severe hearing decline, and that is exactly why it is strictly contraindicated in only hearing ear disease. You just can't take that risk.
Section 5. Summary and next steps. Consolidating the algorithm. Let's bring it all together. Bringing back our treatment ladder, here is what you absolutely need to take away from this explainer. At the base, your lifestyle modifications and oral pharmacotherapies will successfully control 80% of your patients. Acute attacks, they require a fast-acting rescue plan, but remember, continuous suppressants are a massive red flag. They will sabotage central compensation. Now, for that refractory minority, intratympanic therapies provide a powerful bridge to surgery. Start conservatively with dexamethasone and only escalate to gentamicin when the need for high-level vertigo control actually justifies that measurable risk to their hearing. This structured, stepwise escalation, it's literally the backbone of modern Méniere's management.
And that brings us to the end of our deep dive into the medical management tier. In video 6, we close the series with surgical options, prognosis, and future directions, including endolymphatic sac surgery, vestibular neurectomy, labyrinthectomy, the natural history burnout trajectory, and emerging therapies on the horizon. But before we get there, ask yourself, as our medical therapies become more and more targeted, how close are we to predicting exactly which patients will ultimately need the knife? For additional resources, including the full literature review, the clinical cheat sheet, audio overviews, and the rest of this video series, visit AustralianDizzinessClinics.com. Thanks for joining me, and I'll see you in the next one.